Hello there. I'd like to extend a warm welcome to all of you today, and thank you for joining Heart and Stroke Foundation's webinar in collaboration with HeartLife Foundation. We want to acknowledge this very important week as it is Heart Failure Awareness Week. The Canadian Heart Failure Society, together with partner organizations including Heart and Stroke and HeartLife Foundation, are leading the 7th annual National Heart Failure Awareness Week to raise awareness, increase public knowledge, and also to provide a better understanding of heart failure. When you join today's webinar, you will be joined through a computer audio. Questions are welcome throughout the webinar, and please feel free to enter them in the Q&A box as they will be addressed at the end of the webinar. And lastly, the webinar will be recorded and uploaded to the Heart and Stroke and HeartLife Foundation's YouTube channels and the Heart and Stroke Canadian Stroke Best Practice website. The recordings will also be made available at the end of the webinar and provided in a follow-up email. From coast to coast to coast, we acknowledge the ancestral, traditional, and unceded territories of the First Nations, Inuit, and Métis peoples of these lands we call home. We are gathered today because of a shared commitment to equity, including health equity and reconciliation. I encourage you to reflect on what that means for you and your work and in your lives from coast to coast to coast. My name is Shannon Doucette, and I'm the Heart Project Lead at Heart and Stroke Foundation, and I'm honored today to be one of your moderators. Our objectives for today's webinar are to elevate your understanding of the symptoms of heart failure for early detection and intervention, to highlight complexities in diagnosing of heart failure and provide valuable practical strategies for overcoming these challenges in primary care and within your community. And lastly, to share actionable initiatives aimed at fostering a collaboration, patient-centered approach to heart failure management across healthcare providers and also in the communities. I am now honored to introduce you to two incredible partners from the HeartLife Foundation. Mark Baines, co-founder of HeartLife Foundation and co-lead for the Canadian Heart Function Alliance, who will be our second moderator for today, and Jillian Code, co-founder of HeartLife Foundation, who will join us as our panelist for today's webinar. Thank you both for your collaboration. And Mark, please take it away.
Thank you so much, Shannon. Welcome everyone to Heart Failure Awareness Week. This is our fourth webinar that we've had every single year, and every year it gets bigger and better. I am so honored to be a part of this. Thank you, Heart and Stroke, for your partnership in this, and for the Canadian Heart Failure Society and all the work we're doing with the Heart Failure Awareness Week. We have some amazing presenters today that I know personally and professionally. Jenny Milne, who's a personal lived experience of heart failure, also the community engagement manager for HeartLife. We're so grateful to have her. She's going to be sharing her story. Dr. Stephanie Poon, cardiologist and associate professor at the University of Toronto, medical director for the Heart Function Clinic at Sunnybrook Health Sciences Center, and a real advocate for patient-centric care. Love working with Stephanie and her work across the country. And Rodolfo Pike, an amazing individual, acute care nurse practitioner, Heart Function Clinic Science Center at St. John's, Newfoundland, a great friend, and so passionate about taking collaborative approaches to heart failure. We have some amazing talks coming up, and we're going to kick it off with Jenny's lived experience.
Thank you, Mark. This is at our cabin. It's little Max. Some people know him, and also AKA Maxi Man. Next slide. I'm truly honored to be here as a patient partner. This slide kind of represents what you would expect the patient journey to be within heart failure. Next slide. When reality, this is what it actually looks like. Next slide. A little bit about myself. I was in my early 20s. I was active, newly engaged, thriving, building a life with my now husband. Next slide. I've always been active. I grew up as a competitive figure skater, later worked for the city in the ice rinks, loved camping, going for walks, and staying fit and being outdoors. Fitness and movement were a big part of who I was. I met my husband in 2017, and in the summer of 2020, we got engaged in Jasper, right in the middle of what felt like such a hopeful and exciting new chapter of our lives. At 23, I truly thought I was just a young, healthy woman navigating adult life, had no idea that my body already started whispering something that was bigger that was happening. Next slide. Things started to shift in late January, early February of 2021. I began noticing shortness of breath, and it felt like wrong. I started to notice what I thought was my asthma was getting worse. I told myself that I just started a new office job. I was just getting out of shape. However, when I couldn't walk 5 feet in front of me, I knew I needed something was wrong. Then came the other signs, swelling in my legs. By mid-February, I was extremely fatigued, and what I now know were chronic palpitations. I was completely drained, and my body was trying to tell me something. But the scariest part, in November of 2020, months before the breathlessness hit, I went to hospital with distended abdomen, and they ran tests and discovered my gallbladder wasn't functioning. They also found free fluid in my abdomen, and my white blood cell count was very high. Those were red flags, but I was 23 and nobody checked my heart. Everything was chalked up to a non-functioning gallbladder, but we don't know why. I spent about 4 months misdiagnosed, 4 months of feeling worse and worse, knowing something was wrong, but not having answers. It wasn't until I couldn't walk 5 feet in front of me without needing to stop that it became undeniable. I knew this wasn't normal. Next slide. After months of feeling unwell and being misdiagnosed, I finally went to see my doctor. He took one look and listened. He immediately said, "This isn't your childhood asthma. This is something to do with your heart." He ordered a 24-hour Holter monitor, and results were alarming. My heart rate wasn't dropping below 150 beats per minute. That day, he referred me to the internal medicine clinic within his practice, and a few days later, I had a phone consult and was given two options: to either go to the ER the next day and be admitted for 1 to 5 days to expedite testing, or go through the clinic within the hospital, and testing could be up to 5 weeks. I chose to go to the ER, and I truly believe that decision helped save my life. During my hospital stay, I had an echocardiogram that revealed I had two leaky valves and my heart was enlarged, and something was infiltrating it. I needed a cardiac MRI to investigate further, and I was discharged and told to return to the ER if anything worsened. The classic palpitations, shortness of breath, chest pains. Like most heart failure patients, I was readmitted within a week. That's when they discovered I had a blood clot in my lungs. They knew I was retaining an extreme amount of fluid, so they increased my diuretic dose. Over the next 3 weeks, I lost 30 pounds of fluid, and my gallbladder started working again. It explained the breathlessness, the swelling, and the overwhelmed fatigue after losing all that excess water. I stayed in the hospital for about 6 days, waiting for a cardiac MRI. While they still couldn't fully see what was infiltrating my heart, they suspected I also had a clot in my heart. I was discharged on warfarin with a follow-up with my cardiologist a week or two later. At my first cardiology appointment, they believed my condition could most likely be managed with medication, but they still didn't know what or why they were treating. So on May 19th, I had a right heart catheterization and biopsy, which is the middle picture. The picture on, I guess, the right is, I'm not doing a peace sign, it's my second right heart cath. But after the first right heart cath, that's when everything changed. While I was still in the cath lab, the cardiologist came in and said, "I'm going to recommend you be referred to the pre-transplant clinic." That was the moment it all became real. I was only 24 years old at this time. I came out of the procedure in tears, waiting for my fiance to be let back in. The following week, I sat in my cardiologist's office and heard the words nobody expects to hear at 24. "You need a heart transplant." I was diagnosed with endomyocardial fibrosis, a rare condition where the fibrous tissue builds up inside the heart. My mitral valve has severe regurgitation, causing dangerously high lung pressures. Before I could be listed, we had to get those pressures down. Next slide. Despite some ups and downs, I remained an active heart failure patient, but my lung pressures continue to be dangerously high. Every 3 months, I had a right heart cath procedure to monitor the progress, but the numbers weren't improving as quickly as they hoped. At about 6 months, they had only dropped about 50%. That's when we started to explore other options to help my lungs. At first, they considered a mitral clip, but my tissue was too thick and it wasn't a viable option. By the end of January 2022, I got a call from my cardiothoracic surgeon, and he said, I would really like to replace your mitral valve as soon as possible. I'm concerned your lung pressures are close to irreversible. My only other option was a heart-lung transplant, which he strongly advised against, as I would have had to travel out of province, not to mention the complications that come with multi-organ transplants. So I agreed. The plan was to replace my valve and give my body time to recover and be assessed and then put on the transplant list. Then on March 1st, 2022, I had open heart surgery to replace my mitral valve. After the operation, my surgeon, Dr. Chung, came to see me in the CSICU. He said something I never expected to hear. Your pressures have lowered to normal levels. You don't need a transplant for a few years. You can go back to normal life. Next slide. What I know now, looking back, I wish there was so much I knew earlier and so much I've learned along the way. The biggest lesson, it's not normal to be breathless. I had to learn how to advocate for myself, to ask questions and push for answers, and speak up when something didn't feel right. Just before I left the appointment where I was told I needed a transplant, my cardiologist suggested something that changed everything. You should join the HeartLife Foundation's Facebook support group. I requested to join before I even got home. A week later, I joined my first Zoom hangout, and that's when I found my community. They understood the symptoms, the fears, and the emotional weight of living with heart failure. Even though our stories were very different, there were so many parallels. That day, I met another young woman who was on the transplant list. We instantly connected, and to this day, she's one of my closest friends, and I believe in the audience today. As things started to open up during COVID, Naomi and I decided to start in-person meetups for patients in the Lower Mainland, and we still try our best to meet up as much as possible. I will forever be grateful for HeartLife for creating a space where I could talk to others who understand what I was truly going through. My family was always there, but it was hard for them to fully understand. That peer-to-peer support is so invaluable. Next slide. It's been a long road, but today I can confidently say that I'm thriving with heart disease. After my surgery, life didn't just go back to normal. I had to learn how to live with my new normal as I got stronger. We got a dog, Max, who brought so much love and joy to our lives. We had a beautifully intimate wedding in my in-laws' backyard last year, surrounded by our parents, siblings, and close friends. It was everything we wanted, a day full of love, joy, and gratitude. Through it all, my husband was my rock. He worked so hard to support us, making it possible for me to take almost 2 years off of work to solely focus on my health. He never missed a single appointment or procedure. I truly could not have done this without him. Because of him, I'm still here, I'm still growing, and I'm still thriving. Thank you. In the next months after my surgery, my husband and I had a lot of conversation about what's next. Now that I was well enough to return to work, I really had to think about what I wanted to do with this second chance. I knew I wanted to get into advocacy, but at the time I had no idea how to turn that into something tangible. So I took an admin job. Then in 2023, I attended the women's conference and I had a conversation with HeartLife's co-founder, Jillian Code. She mentioned that they were looking to bring someone onto the team. I immediately messaged Mark. And then in the following August of 2023, I officially joined HeartLife as the community engagement manager. I now get to advocate, connect, and help create change for people across the country who are living with cardiovascular conditions. Since joining HeartLife, I've had the opportunity to do incredible work. I've traveled to Ottawa and participated in the first ever annual HeartLife on the Hill, meeting with senators and members of parliament, and even witnessing a bill being presented. In 2024, I helped disseminate over 30,000 HeartLife resources across Canada. My journey has led me to HeartLife and led me to advocacy. It led me to a role where I get to support and uplift others. I found my purpose, the dream job I never knew I needed, sharing my story and supporting others as they navigate theirs. Next slide. I've added a couple quotes that were very meaningful to me in this slide. I've learned from my journey that community and connection matters just as much as medication. I've learned that it's okay to carry mixed feelings about your journey. I'm learning to sit with the complexity. I'm proud of the work I get to do, and I'm proud to be a part of a community that believes patients aren't just recipients of care, we are partners in shaping it. And most importantly, it's not normal to be breathless. Next slide. Thank you. It's truly about life, not failure.
Wow. Jenny, thank you so much for that. I mean, we are grateful, and not just HeartLife, but as a community, as a country, to have you, A, share your story, but be then part of advocating for change. Jenny's story, I mean, your story is unique, but also a lot of misdiagnosis, delayed diagnosis happens across the country. And you're right, it's not normal to be breathless. And we're going to talk a little bit later about this and get into the question and answer. But what struck me was now you're thriving. And I think with the right tools, support, and resources, people can live the quality of life they deserve. And your story is a testament to that. So thank you so much for sharing that lived experience. And it goes well into our next presenter, Dr. Stephanie Poon, who's going to talk about what's happening a little bit across the country and needs around heart failure. Dr. Poon, I'm going to pass it over to you.
Thanks very much, Mark. It is my absolute pleasure to be here today. For those who think that Toronto is a concrete jungle, we do have rare glimpses of beauty, even in the heart of the city, when the cherry blossoms open up for a very short period of time in Hyde Park. Blink and you'll miss them, but they are there. Next slide. These are my disclosures. Before we begin, I would like to talk about why this is an important topic that is worthy of our attention today. Heart failure has come to be recognized as the most rapidly rising cardiovascular disease. Like Jenny, about 1 in 3 Canadians have been touched by heart failure, and every year 100,000 new people are added to that list. It is a condition that results in high rates of hospitalization and mortality despite recent advances in medical therapy. We know that 62% of patients presenting to the emergency department with heart failure are admitted, and that once they are hospitalized, their length of stay is 9.5 days. After a hospitalization, the 30-day readmission rate is 21%. Overall, heart failure is estimated to cost our healthcare system $2.8 billion by 2030. And yet, 4 out of 10 Canadians do not know what heart failure is. So, how do we improve these dire statistics? Well, education and early detection of this disease are important solutions to this problem. So, when should I suspect that my patient has heart failure? Patients with heart failure may experience dyspnea, fatigue, increasing peripheral edema, orthopnea, PND, cough, and episodes of rapid weight gain within short periods of time, which is oftentimes indicative of fluid retention. However, the presence of symptoms oftentimes depends on how decompensated they are. It is important to try and screen for risk factors which may contribute towards the development of heart failure, like hypertension, diabetes, and coronary artery disease, to name a few. However, other investigations which may be useful in routine screening of patients for heart failure include ECG, chest X-ray, echocardiograms, and in particular, natriuretic peptide testing. Natriuretic peptides are currently the gold standard for biomarkers in heart failure. They can be used to help us figure out whether someone presenting with shortness of breath has heart failure or not. In addition to completing your usual history, physical exam, routine blood work, chest X-ray, and ECG, all you have to do is order a natriuretic peptide level. If the NT-proBNP levels are less than 125 or BNP levels are less than 50, then it is very unlikely that the person has heart failure. However, if the natriuretic peptide tests are above these thresholds, then they may have heart failure, and further testing, such as an echocardiogram, would be warranted. As a result, the Canadian Cardiovascular Society Heart Failure Guidelines recommend that natriuretic peptide levels be measured to help confirm or rule out a diagnosis of heart failure in patients who have dyspnea of unknown etiology. This is a strong recommendation based on high quality evidence. However, not only can natriuretic peptide levels be used to diagnose patients with heart failure, they can also be used for risk stratification and prognostication. On any given day, there will be variations in natriuretic peptide levels, but typically this will be somewhere in the 25 to 30% range for NT-proBNP levels or 40% for BNP levels. However, if the natriuretic peptide levels rise above these thresholds, this is our first warning that the patient may be experiencing worsening clinical congestion. And then they may require more frequent follow-up and possible intensification of their heart failure therapies. Natriuretic peptide testing can also determine whether your patient is decompensated to the point of acute heart failure. Now, these thresholds differ for BNP versus NT-proBNP, and NT-proBNP levels are even further stratified by age, as illustrated in this figure. If they end up getting hospitalized for acute heart failure, we really want to see a greater than 30% decrease has been achieved in natriuretic peptide levels before discharging the patient home. And the importance of this is highlighted in our Canadian Cardiovascular Society Heart Failure Guidelines. If natriuretic peptide levels remain elevated, clinicians should reevaluate the patient's condition and consider the possibility of delaying discharge to further optimize therapy and reduce the natriuretic peptide level. Now, why is this important? This is because we know that lower natriuretic peptide levels lead to better outcomes in the long term. This trial found that a NT-proBNP level of less than 1,000 by 90 days after heart failure therapy was associated with a lower adjusted hazard of subsequent heart failure hospitalization or cardiovascular death and all-cause mortality. We as Canadians are not the only ones to recognize the importance of natriuretic peptide testing for patients with heart failure. All around the world, international guidelines have also emphasized the need for using natriuretic peptide testing to diagnose, risk stratify, and establish a prognosis for patients with heart failure. So you would think that such an important diagnostic test for heart failure should be readily available across the country, right? Well, the Heart and Stroke Foundation released results of their heart failure resources and services inventory in 2022, which was designed to gather comprehensive information on all resources and services to people with heart failure within acute care centers in Canada. Data was collected from November 2020 to December 2021. And despite the fact this was way deep in the COVID pandemic, response rate was remarkably high. 501 out of 649 sites answered the survey, which represented 95% of all the heart failure admissions in Canada during this time frame. Out of all the sites in Canada, 30% of all surveyed sites did not have access to natriuretic peptide levels, as demonstrated by the bars in yellow. Access to on-site natriuretic peptide testing was particularly challenging in Nunavut, Newfoundland, and Manitoba. So essentially, if you were a patient in Manitoba, you would have to pay $30 if you wanted to get natriuretic peptide testing at your local lab instead of the heart function clinic. In Nova Scotia, a healthcare provider has to write "do not cancel" if they want to order natriuretic peptide levels for the patients more than once every 6 months. Otherwise, the test will be automatically canceled by the labs. A patient in Ontario was charged around $80 for this test at their local lab until 2021, when Ontario Health started funding NT-proBNP testing. And this was due in part to the findings from a report released in May 2021, which demonstrated that natriuretic peptide testing was not only desired by people living with heart failure, but overall was also shown to be highly cost-effective, with an estimated savings of about $20 million in community care. As a result, Ontario Health recommended publicly funding NT-proBNP testing for the diagnosis of people with suspected heart failure in the community and emergency department settings. And although we are extremely grateful that the Government of Ontario has continued to renew funding for NT-proBNP through this pilot project, we hope to see this important clinical test become a core part of OHIP funding to ensure continued equitable and sustainable access for all Ontarians moving forward. To this end, the Canadian Cardiovascular Society has joined with the Heart and Stroke Foundation to highlight this critical need to our policymakers. So to summarize, natriuretic peptides are the gold standard for biomarkers in heart failure. Natriuretic peptide testing is useful to diagnose heart failure, risk stratify patients with heart failure, establish prognosis, and even to identify patients at risk of developing heart failure. However, natriuretic peptide testing still cannot be accessed in roughly 30% of acute care centers across Canada. We need to work together to ensure that all people in Canada have equitable and sustainable access to natriuretic peptide testing. The more voices we can add to our advocacy efforts, the more impact we will be able to have at finally being able to close this gap so that all people living with heart failure in Canada will have the best possible outcomes. Thank you very much. And it is my absolute pleasure now to hand it over to the next speaker, friend and colleague, Rhodey Pike, who will continue the conversation from Newfoundland.
Thank you very much, Stephanie, and a great segue into my next segment. I'd also like to thank HeartLife Foundation and, of course, the people with lived experience, because without them, we wouldn't be doing the work that we're doing to get this to manage heart failure in Canada. I also like to thank Heart and Stroke for the invitation to participate in this webinar as well. So we all had to provide a personal picture, and I love pictures of icebergs. And just to show you this monstrosity that was just south of where I live on the Avalon Peninsula. But what's interesting about icebergs, only about 1/3 of it is above the surface. So that's the only part that you see, with 2/3 actually being under the water. And that's somewhat of my approach to when I go in and see patients. I don't only look at what's immediately in front of me, but explore so that I can actually assess the whole person and from that whole perspective. And to that end, I will move on to the next slide. These are some of my disclosures. Next slide. So today I'm going to talk about developing a provincial heart failure program to improve early diagnosis and access to care in our province of Newfoundland and Labrador, with using BNP measurements to sort of guide our decision making. So to sort of set that stage, it's very important to actually look at the prevalence of heart failure in Canada, but more precisely look at it in our small province. So we got a crude prevalence of about 3.94% nationally, and in our province we got a little bit of a higher level at 4.1%, with an average of about 14,000 people perceive living with heart failure in Canada. So we know what the the prevalence is, but how is it that we manage to ensure that all those patients who are living within our communities are getting the appropriate identification, modified by their risk factors, and getting the appropriate testing to give them the diagnosis of heart failure? Next slide, please. So I'd like to just take a step back and to sort of identify how we sort of came about developing this project. So I was very active in the heart failure RASI, and then from that we also developed a heart failure action plan advisory committee. And from that there were two large roundtables that were sort of done a year apart, and looking at how we could set goals from a cross Canada perspective, and for us to try as clinicians and also people with lived experience, how is it that we can move that needle so that we can improve outcomes for heart failure? So to that end, 5 goals were set by this committee. 1, integrated systems of care. 2, evidence-based care, so that if you're diagnosed with heart failure, how is it that we can get the diagnosis, but more precisely, how is it that we can get you on the best possible treatment? Also, how is it that you can get access to specialized heart failure care to ensure that you get the best outcomes, coordinated and seamless transitions of care, and support for people living with heart failure and for their families and caregivers. But if you look at the two that I have highlighted in red, that's the two that was sort of our approach moving forward of how is it that we look at getting the evidence into practice, but also how we can do novel strategies for getting access to specialized heart failure care. Next slide, please. So clinical use of BMP. So BMP is not a new concept. It's been in the heart failure guidelines dating back to 2013, but it's been quite a uphill climb for us to get access to it here in Newfoundland. Prior to initiation of BMP testing, we only were able to access NT-proBNP from an out-of-province perspective, so actually having to send a sample off-site, and that was generally for patients who were diagnosed with heart failure, who had them in clinic, they were improving from a diagnostic perspective, their heart function was improving, but they still had a high symptom burden and wanted to exclude, are we still looking at heart failure as the main driving factor for their symptoms? So that was number 2, but we didn't have it as an initial diagnosis or exclusion of heart failure. So to that end, we undertook some work and some advocacy within our own government and to lead us where we are today. Next slide, please. So as Stephanie highlighted, the heart failure RASI result was quite insightful with the high return of responses from the people that it was sent out to, including 95% response rate. So if you look at Canada at the time, there was only 44% had access to BMP testing, and in our own province it was 22%. But again, that was never on-site testing. That was actually at a province because there was no organization within our province that was actually doing BNP testing at that time. So to that end, it was quite easy to make an argument for this important test to become a part of our clinical pathway. Next slide, please. So to that end, we came up with, trying to get the BMP testing, get it approved for the province. And to support that, we also started working with an algorithm that if we did get BMP testing, how is it that we can actually put it into practice in primary care providers? So when patients first present with the symptoms of shortness of breath, they're showing up feeling fatigued, they have increased swelling or edema in their legs. And so we came up with one of our cardiologists, actually, Dr. Sussex, to always think heart failure. If you're in doubt, you can't rule it out. Think heart failure as one of your competing diagnoses to ensure it's not missed. Next slide, please. So our journey began back in 2022 with sending information to the Provincial Laboratory Advisory Council and a briefing note to the Department of Health. By August 2022, we approved for Eastern Health to include BNP testing to the lab formulary, sorry, and that was a limited rollout to a central location, but it was also mostly only for specialist ordering. And if primary care actually wanted to order the test, there had to be a special provision or special authorization form to accompany it while you were ordering it. Then we went on to proceed with the the education component. And then from there in May of 2023, we had BNP testing offered at St. Clair's Hospital with provincial referrals coming in. So we did that for over a year, and then in January of 2025 this year, we have full implementation across the province of BNP testing, and it is open for testing to all primary care providers, all specialist care within the province. So there are no longer a special authorization form to be completed to get the test completed with no restrictions on repeat testing as well. And I found out after returning from our conference on the weekend that as of the fall of 2025, we will also be offering NT Pro BNP testing within our province, and again with no restrictions in ordering. Next slide, please. So now we have BNP testing. So what's our next step in the plan? So we know that from historically that a lot of patients, by the time they present to our clinic and you sort of look at their journey, there have been many presentations to outpatient type clinic settings, sometimes frequent visits to the emerge before we actually get the diagnosis. So if a patient presents with dyspnea, clinical assessment performed, and they have the risk factors that were highlighted and other comorbid conditions, think heart failure. If you can absolutely rule that out, you go down another pathway. But if you can't, then always do a BNP. Get your BNP result back if it's greater than 50, or if it's with special considerations such as atrial fib, maybe a little bit higher. We know that we're dealing with heart failure. Refer to internal medicine or cardiology to get the appropriate workup done and establish the diagnosis of the phenotype of heart failure. But in short order, you can start 2 medications, SGLT2 and an MRA until the left ventricular ejection fraction is confirmed, with other diagnostics such as your echo, blood work, EKG, and chest X-ray. We've even taken it one step further, and I've also provided criteria, which is in the orange box to the right, that direct referrals to the heart failure clinic if you got a BNP greater than 50, and if you've had prior emergency visits and or hospitalizations for heart failure in the previous 6 and 12 months, or if they get a BNP greater than 500 and absence of severe comorbidities that or poor functional status limiting their benefit in the clinic. So we've taken the BNP testing, we've now moved it so that we have the result, we can get the test completed. So how is it now that we can roll it out and be implemented so that we can get that early diagnosis, so that we can establish early GDMT to improve outcomes of improved mortality, decreasing hospitalizations, and improve reverse remodeling. Next slide, please. So our next project that we did is how is it that we actually enact or able to get access to patients to get appropriate treatment for heart failure. So we joined a partnership with our RPM clinic, and with that, all patients who are now registered within our clinic, but we need up titration, and some of those patients could be as far as 1,100 kilometers one direction from our clinic. We only have 2 heart function clinics in the whole province. So we now send them out an iPad, we send them out a blood pressure cuff and a weigh scale, and we are able to do full optimization of all their therapies based in certain parameters from afar using this technology and a remote patient monitoring nurse. Next slide, please. So prior heart failure management, there were 2 clinics, about 900 patients in total. Remainder of heart failure patients are managed by primary care and specialist care. And like I said, no access to BNP testing. Next slide, please. So this is just a map of some of the far-reaching patients that we currently have because we are challenged by geography. So no matter where you live in our province, as long as you have cell phone access within that area, that's how the platform is run, we're able to actually provide you with optimization of your GDMT. Next slide, please. That's our clinical pathway of how the first visit is usually done in person, but we've even moved away from that, and it can be direct referral to the virtual optimization clinic and what that schedule may look like. Next slide, please. And these are just some of our stats that we had done a couple of years ago. After 12 months of experience, we had 112 patients. 41 was currently involved in undergoing optimization. And we were actually able to up titrate patients at an average of 9 weeks to optimization, and that's below the 3 month. That's generally recommended. And if traveling to in-person heart failure visits, 33% of our clinics patients would have to travel in excess of 400 kilometers round trip to come to clinic to have up titration. And there's been a high degree of patient and practitioner satisfaction. So I'll end at that note, but some key messages, I'll leave that to Mark. Thank you.
Rody, thank you so much for that presentation. Stephanie, you as well. We appreciate your time. I mean, and kind of going through the day, we started off with the powerful patient voice with Jenny Milne, reminding us why this work is so important, that the lived experience really brings urgency to raising awareness about heart failure in this country, that educating patients, families, and clinicians on recognizing the symptoms early and seeking timely care can change lives. And then Stephanie came in and really talked about the status and role of NT-proBNP in diagnosis and management. And it is a critical biomarker for heart failure. It can support early diagnosis, it can guide treatment decisions, and monitor disease progression. And it's readily available. And it really emphasizes how integrating, I think, NT-proBNP into routine care can reduce diagnostic like uncertainty and improve patient outcomes. And then Rody finished it off with how do we implement this evidence into practice? And I think we can all look at our friends in the Atlantic provinces and say, this is the gold standard on how we can implement heart failure care, right? Real practical strategies I think we can look at across the country to not only diagnose heart failure, but then look at optimization of guideline-directed medical therapy. Rody, I think you said, as long as you have a cell phone, we can get you on guideline-directed medical therapy. And that's where we can go, I think, across the country for heart failure care. It starts with hearing about the patients, the caregivers, their needs and objectives, looking at the evidence, and then implementing these strategies. Thank you so much to all of our amazing presenters. I'm going to ask that you come on to camera, everyone, so we can have a few questions and answers. Perfect. Fantastic. I think we have everyone up. Jillian, I'm gonna start with you. Get you going. I hope you're warmed up from hearing all of that. You heard some great conversations. You have a lot of experience in the space, lived experience, as well as advocacy space. What are some of the most effective ways to support individuals living with heart failure and their caregivers in the community?
Thanks, Mark. I certainly am warmed up. And I just want to thank each of the speakers for sharing your insights, and especially to Jenny. You are incredible. Thank you for your bravery and sharing your story. There's a number of ways that you can support people with lived experience and their caregivers in the community. The first one, I think, coming from HeartLife, it's probably obvious, but the peer support networks are extremely important. So ensuring that patients and their family caregivers are connected to others with lived experience really helps to reduce that isolation and does help build resilience, and they learn from each other. So HeartLife obviously has, we have our own Health for Hearts community. Heart and Stroke has a community as well, and we also have a women's only community run by the incredible Jackie Ratz, Canadian women with medical heart issues. And so there's lots of ways to, and you don't just have to join one, you can join them all. To really get out there and to learn more about what's happening, but also to connect with others. Accessible education. So, for example, we have the HeartLife Academy, so that provides clear and culturally sensitive and stage appropriate information education just in time that is right for you. To help really the idea of mental health support also comes along with that. So the peer support networks, along with the education, really does help. Obviously, it would be great if all clinics and care teams had mental health support available, would certainly help. And finding integrated care teams, hopefully working with them. And something that Jenny also talked about as well is education and empowerment. I think through through the support that people can get from within the community, they do become more educated, but they also become empowered, and through that becomes they become more empowered and better able to advocate for themselves, but then potentially advocate for the community at large. So there's lots of different ways that people can get support, but that's where I would start.
Fantastic. I mean, that's a great start. I mean, there's so many options and so many different ways to look at it. Like you said, from a mental health perspective, also looking at that peer-to-peer support, then getting into that education in the community. You also mentioned integrative care. And so I'm going to touch on that. I'm going to reach out to Dr. Poon. How can we ensure there is more of a consistent and collaborative heart failure care approach across different healthcare providers and communities across the country?
Yeah, well, that is definitely the $1 million question, isn't it? I mean, I think we all know that it really truly takes a village to take care of people with heart failure well. And, most centers work in silos, and that is the unfortunate nature of it. And not only that, if you look at it, there's a perception that sometimes heart failure should be managed by heart failure specialists, but that isn't the case across the country. Most patients with heart failure are actually being seen by primary care practitioners or general internal medicine specialists, not just cardiologists, and heart failure specialists probably only see the very tip of the iceberg, to use Rhodey's analogy. So really, I think the key to making sure everyone gets the right care at the right place in the right time is to ensure that everyone who manages patients with heart failure uses the guidelines that we have. They're fantastic resources in terms of the algorithm to know when to think about heart failure in your patients, right? It's not normal to be breathless, but also kind of the series of tests that you should think about ordering so that we don't have misdiagnoses and months of not knowing why people are having the symptoms they're having. And oftentimes, if you pair it with the qualitative symptoms of something quantitative like an NT-proBNP test that is elevated, that definitively answers a question, and that can actually facilitate access potentially to specialists who cannot ignore an elevated natriuretic peptide level. But if you just say, please see my patient who's short of breath, you may not get the same access to, say, cardiologists or heart function clinics. There's also the necessity of making networks, right? So here in Ontario, we have started many sites at integrating what we call the spoke hub node model of integrated heart failure care, where the node sites really see the most complex, challenging patients, but as they stabilize, they can be moved out to community hub centers, which may entail cardiologists or internal medicine specialists, and then finally to the spoke level, which is primary care. And it's ensuring that all patients at every level are fully supported, and that our primary care colleagues can also have access to us if needed and the resources that they need to be able to manage these patients well. So it definitely is a solution with many pieces to it, but I think we're learning that we really do need to work together as a team to be able to manage and provide the best quality of care for our patients.
Thank you so much. And you're right. It's presenting the facts and how do you argue then with the facts to start to implement levels of care. And I agree with you. I think that it takes that integrated approach, and primary care is a big part of this. A lot of management of
Absolutely.
heart failure, and I don't know the percentage, but I think it's over 85% of heart failure care happens in the community. So primary care is an integral part throughout the
Absolutely.
entire journey, which leads me to my next question, Rhodey. When it comes to primary care, Stephanie emphasized the importance of it. How can we collectively, patients, heart failure specialists, nurse practitioners, just generally create awareness for our primary care physicians around the diagnosis of heart failure?
Yep. So I think one of the key things is getting the message out there, identifying that the work often starts at the primary care level. There's been a couple of papers actually published that with before the initial heart failure or the index heart failure hospitalization. So when that patient presents to the emergency department or to the hospital in acutely decompensated heart failure, there has been an actual number of increase visits to primary care provider. And sometimes it's even within that month prior to getting that index hospital admission that their actual contacts to healthcare providers have increased. So we know, and when we see a patient in the clinic, we know that just listening to their journey, that this is happening sometimes months. It can happen overnight, can happen in a few days, but generally, if you ask about their journey, it's looking at where they were 6 months ago, and you can often tell that those symptoms were building. And just as Jenny had explained, it's that trajectory over a number of months. So how is it that we can actually provide education programs, develop quality initiative projects like the ones that we did here in Newfoundland to actually support primary care? So if you get that person in, they are breathless, they are fatigued, they do have some edema, think heart failure. If you can absolutely rule it out, fair enough. We're good with that if you got a pneumonia, high temp, so on and so forth. But if you can't, this simple test, and by simple, I say put it on a requisition, give it to the patient. It's going to the lab, it's going to get done. When you get it back, you got your answer that it's elevated. Now I need to move, and this is the process that I have. I've established that heart failure is the working diagnosis. Then we can start our GDMT so we can get you on the appropriate medications. But the thing about it is that we can't do that without providing and supporting those people in the community. As Stephanie highlighted, we don't have access to specialized heart failure clinics. 2 in our province perceive 14,000 people. There's no way that we would be able to see all those patients. But if we get the diagnosis, we have the correct clinical path, we've actually integrated best care for heart failure management into the TELUS EMR, which is used in about 85% of our primary care clinics. We only have one, so we're not going across multiple systems. So we're a bit unique in that way. So we can build the system that now I have heart failure, click on the link. These are my guidelines. Then it'll even prompt me. Do you have this patient on GDMT? Are they on an ACE ARB? Are they on a beta blocker? Are they on MRA, SGLT2? So we also built things within our system that will actually prompt you to provide the best care for heart failure care and management.
Wow, I think Stephanie points out in her presentation that sometimes we operate in silos across the country when it comes to healthcare, but cardiology and heart failure care. I mean, I think we should all implement your system, Rody, and bring that across the country for this integrated care approach. I want to touch, just bring this to Jenny. So from a healthcare perspective, Rody and Stephanie both talked about the diagnosis, the NT-proBNP, how we can create awareness for primary care physicians. From a personal lived experience, patient caregiver, what's our role in creating awareness around heart failure symptoms and really creating that awareness around, think heart failure?
Thanks, Mark. I think I have a kind of a unique approach to it because I was so young when I was diagnosed. I guess as we talk about in at like heart failure update with our zebras, like if you hear hooves, don't assume horse. It might be something else. Or I guess the other analogy we use is not all zebras have the same stripes. Not all heart failure patients are the same. It wasn't until recently that I had heard of another young person that presented with a non-functioning gallbladder, because she was retaining so much fluid. Uh, but she actually had her gallbladder removed, but I was too sick by the time I was supposed to get mine removed that they were like, we're gonna hold off on this surgery. Um, I think even just seeing the random symptoms like the free fluid in my abdomen, I didn't know that meant that I was starting to retain fluid. My restrictive cardiomyopathy, pardon me, presents in my lungs and in my abdomen first. There was so many times, even throughout my heart, like once I was diagnosed with heart failure, the amount of times I was asked, well, do you have swelling in your legs? And I was like, I don't get swelling in my legs until it's really bad. I notice it in my abdomen and I notice with the shortness of breath. So I feel like it's more listening to your patients and also advocating as a patient. Like it's not, I've said it so many times today, it's not normal to be breathless. And the fact that even my doctors think that it was a slow progression of heart disease, and I never had asthma because I was so young, and there was family history of asthma. I hope that answers your question, Mark.
Yeah, it's you're right. It's not normal to be breathless, right? And that's it. And people have to start thinking heart failure, and it starts with recognizing the signs and symptoms. I know we have 5 minutes left. Shannon, is there any questions in the chat that I missed that we need to get to?
Yeah, few, whether Rhoda or Stephanie, you either want to reply or not. How often should a patient with existing diagnosis with heart failure be tested to monitor BNP levels? And would this actually provide more of a timely identification of decompensation?
Yeah, that is a great question because there is no guideline directed answer for it. So it is a little bit of a gray zone. But if you look at some of the studies that were published in JAMA, one in particular by Dr. Felker, it does suggest that perhaps even patients with chronic heart failure should have their natriuretic peptide levels tested every 3 months. Now, of course, if your patients are super stable and you've been following them for years and years and nothing has changed, maybe something less than that is appropriate, right? Maybe then the every 6 months or so time frame would be more appropriate. However, if your patients, on the other hand, are not doing so well and decompensating for unknown reasons, or if you're just in the earlier phases of medical optimization, maybe you want to be checking the natriuretic peptide level a little bit more frequently because it can be used to help you risk stratify and prognosticate as well. So I guess the bottom line is there is no guideline directed answer for this. And oftentimes we are kind of guided by how well our patients are doing in front of us to determine how often we should be measuring it.
Thank you. I think that as looking at the time, we are at perfect timing. So I want to thank everyone for really thoughtful questions, but also an excellent discussion. And on behalf of Heart and Stroke Foundation and HeartLife Foundation, we want to extend a heartfelt thank you to all of our presenters today and for everyone who took the time out of your day to expand your knowledge and awareness of heart failure. This has been an incredible webinar. And just a reminder that a recording of this webinar will be uploaded and available on the Heart and Stroke and HeartLife Foundation's YouTube channels and the Heart and Stroke Canadian Stroke Best Practice website. And after today's webinar, a follow-up email will be shared that will include the recording to the webinar and a webinar evaluation. We do invite you to complete an evaluation, which will lead you to a certificate of participation for today's webinar. And for further information, resources, supportive tools, we really invite you to visit the Heart and Stroke and HeartLife websites, including other excellent patient education and healthcare provider resources from the Canadian Heart Failure Society. And we also hope to see you all very soon at Heart and Stroke's upcoming Stroke Month webinar, held on June the 17th at 12 p.m. Eastern Standard Time, where they'll be discussing vascular cognitive impairment, advancing evidence-based care across the continuum. Again, a heartfelt thank you to everyone and to our presenters today. And I wish everyone a wonderful day.